Welcome back to the Many Faces of Alzheimer's, brought to you by the Institute of Memory and Cognition at Tala University Hospital, Dublin. I'm Fionnuala Sweeney. In this podcast, we hear more from occupational therapists Emma Nolan and Fiona Tobin about their involvement in the process of reaching a diagnosis and in supporting patients and their families after diagnosis.
My name is Fiona Tobin. I'm a clinical specialist occupational therapist working in the memory service.
And my name is Emma Nolan. I'm a senior occupational therapist working here in the memory service.
Can I ask, what does occupational therapist mean?
You're not the first to ask that. Occupational therapy is concerned with supporting individuals to carry out the daily activities that are of meaning to them. So occupational, in its standard sense, is understood by people to mean the job that they do, the occupation that they've chosen to study in or work in across their life. But we would see occupation to be much broader than that. Occupation starts from when you wake up in the morning and you're carrying out your personal care, you're washing, dressing, grooming, doing your hair, getting ready for your day. You're moving on then to kitchen tasks, feeding yourself, cooking, your domestic chores, all of your housework, your instrumental tasks, so things like doing your shopping, paying your bills, driving, and then your leisure, all of your hobbies.
All the things that occupy you.
All of the things that occupy you, all of the things that are of meaning and importance to you.
So the occupational therapy role in the memory service is involved in both the assessment of cognition from the pen and paper point of view, but we also do specialised functional assessments to try and work out whether or not somebody's changes in daily routine is due to a physical symptom as opposed to a thinking skill. And then for people who have got a diagnosis, Emma is very involved in providing post-diagnostic supports in terms of the optimising cognition group.
So let's talk about what happens first when people have been referred to you. What is the process?
Our sessions probably follow a similar enough format. When the person first comes in, we spend a lot of time actually discussing the referral with them and making sure that they understand that we are looking for something that could possibly be neurodegenerative, because obviously that's a big lifestyle change. And we want to make sure that the person themselves is fully consenting to undergoing the process. Then we would take a detailed history from them, what changes they've noticed in their daily routine. And where possible, we would also get collateral from a family member or somebody who knows them well to see has anyone objectively noted it, because sometimes people are worried and everyone else says, I know there's nothing wrong with you, but the person's still very concerned. Following that, we would do objective measures of their mood and their sleep, again, to rule out any other mitigating factors. Then we'd follow through with the neuropsychological assessment, so the Addenbrook's cognitive assessment and the Orban's, alongside a screen of executive function, which we use the FAB. And following that, if needed, we would bring them in to do an objective functional assessment, which is the AMPS.
Does this all take place on one day in one sitting?
The majority will. Our functional assessment will be separate, but the collateral history taking and the neuropsychological assessment, if the person can tolerate it, we would do it in one session. So it can be 2 to 3 hours, which is a long time for the person, but they tend to warm up as we go along. And if we break it, then you may have changes between sessions that are other factors, not necessarily cognitive related.
We heard at the clinical case conference about the kind of detail that you would take from somebody that's been referred to you and their spouse or a family member, someone accompanying them. It does require quite a skill to find out what's really going on in the house.
Yeah, I think that comes with time and actually not being afraid to ask the hard questions, explaining how the session is going to go and that we are looking for change from the baseline, and that anything we ask isn't to judge, it is actually just to try and help. For example, if people are talking about maybe having hallucinations, they feel like they're losing their mind and they feel like we might judge them for that. And the same with alcohol or illicit substance use, they feel judged. So we try to spend a lot of time building a rapport. And again, we take it at the pace of the person. If we don't think that they're going to be able to manage all the assessment in one day, we will offer them breaks and we will offer them the opportunity to come back. We're also very clear in our sessions that they can stop at any point and that there'll be no impact on their future healthcare, or if they want to come back to us, it's all at their pace because they're the people who want the answers. It's their story and we've got the privilege of hearing it.
It's the person-centred approach.
Yeah. What we would usually be looking for is trying to get a good sense of a person's baseline, so how they would have managed their day-to-day routine and occupational routine historically, and has there actually been a change from that? And again, we tend to ask very much about their daily routine, their ability to manage their cooking, their finances, their transportation, their hobbies. I get laughed at by one of the consultants. I always ask the dogs' names, because if a person comes back to you again in the future, you can ask, sometimes that icebreaker is, oh, how's the dog, or how is... And even if you don't fully remember the whole story of the person, I make a note of it on my notes, because again, they feel that they are the centre of that consultation, that you've really put that time into remembering them, and they do open up and disclose an awful lot more when they feel heard.
And the whole point is to make people feel comfortable enough to do so.
And I think we do have a lot of skill in that therapeutic use of ourselves by being very clear when we meet them first about our role, that participation in the process is their decision and how important consent is, and for them to know exactly what it is we're looking for, the purpose behind each of the measures that we're doing, that they're not exploratory questions for the sake of exploratory questions, that there is a link between this particular piece like mood or sleep and cognition, and that's why we're asking. I think people, when they understand the purpose behind all of our questions, they really understand the process that we're following. And as well, we take really good care of their well-being throughout. If somebody comes into us and they're feeling very stressed or anxious about potentially what their symptoms could mean, it may be that first appointment is just a supportive discussion, and that they go away and reflect and think a little bit more and decide, do they want to pursue this? And understanding what the different pathways would be if they do or if they do not explore it.
A really common thread running through all the conversations I've been having this week is this building of rapport and trust. And that is the foundation really for coming to a potential diagnosis and then taking measures afterwards.
Exactly. It's so important to us as well as occupational therapists. It's core to our training, that person-centred care and therapeutic use of self. It's very evident across all of the memory clinic team. We want them at their best, and if that's today, great. And if it's not, we'll bring you back in a couple of weeks, and that's perfectly fine.
What happens then once a determination has been made at the clinical case conference about how to proceed?
So a decision will be made at that case conference about whether any further investigations are needed or onward referrals to other professionals on the team for further assessment. If it is that those assessments are needed, the referrals will happen there. The person will come back and see whether it's the neuropsychologist or the speech therapist or ourselves if we haven't done the initial intake. They will then have those assessments and their case will be discussed again with the results of those assessments. If it is that the person doesn't need any further investigations, then they will come into clinic, meet with the medical team and the consultants, and diagnosis will be given at that time. Kathy McHale is the advanced nurse practitioner who is predominantly responsible for the post-diagnostic pathway here. So she would meet all people who have received a diagnosis of a dementia and offer supports. From an occupational therapy point of view, we obviously focus on intervention from a therapy and an occupation and a function perspective. For people who are receiving diagnosis of perhaps a subjective memory complaint or a mild cognitive impairment, we offer them our cognitive rehabilitation program, OptiCog, to teach them memory strategies. For people who are receiving a diagnosis of a dementia, the therapy that's offered is a little different. They would be referred to a cognitive stimulation program that's delivered externally to our regional specialist memory clinic here. We would see them for assistive technology, so external aids, external environmental supports. For example, somebody is having difficulty with wayfinding and getting lost in the community, perhaps a GPS tracker with their consent, something that they might like to consider. Features at home such as a bogus caller alert on the door, so if somebody comes to the door that they don't know, they have a way of raising an alert, or something like a video doorbell that family can see who's coming to the door. So there's that layer of protection there. There's a document developed within our adjacent integrated care service that we would also use called Safe and Found. It's a document that people would fill out so that if wayfinding is difficult or there's potential for them to get disoriented in the community and maybe become lost, there is a document with all of their details, their name, their height, their weight, places they like to go, places that they maybe would have lived previously that they may try and navigate back towards. And that lives with the family, so it's readily available to give to the Gardaí should the person become lost. That just takes the stress out of that moment for the family of trying to answer 1,000 questions when a person is maybe missing. Also things like our service runs a family support training, so providing family, friends, significant others with advice and education around how to manage symptoms, how to support function, how to support people to maintain engagement in activities that they've always enjoyed, but that are maybe a bit more problematic for them now.
And then what kind of recommendations would you typically find yourself making for people who are struggling with day-to-day tasks that they would have carried out ordinarily? Are there changes that can be made in the home?
Absolutely. The particular intervention that we will recommend or the particular support we will recommend will very much depend on the diagnosis that has been given. For a person with, for example, a mild cognitive impairment, their function isn't impaired per se, but things are more difficult and more problematic because of the symptoms that they're having. We have our cognitive rehabilitation program, OptiCog, and the purpose of that is to educate people around their cognition, around the symptoms that they're experiencing and how to manage those, whether it's their memory symptoms or the functional impact of those. So showing them strategies, how to set up their environment at home to support their memory, to prompt them around areas that they may typically be forgetting, to help support their routine, help them maintain that functional independence that they have. Say, for example, there is a person and they are greatly struggling to remember where they've placed items that are pertinent to their day-to-day function. So they're losing their mobile phone, they're losing their car keys, and these objects are important to the tasks that they're going to do for the day. They need them before they leave the house, but they're now late for appointments, they're late for work, they're late for whatever it might be because they can't locate those items. So we might be teaching them a strategy for everything having a set place in the home or having a labelled location where you put all of those items that you need. So each day when you're going to put down those items, you leave them in that exact same spot. So you know then that that's where your mobile phone lives, that's where your wallet lives, that's where your key lives. By them getting into the routine of putting those items in that place every day, their whole routine can run smoother.
Do you find that people are generally responsive to that kind of guidance? Because people,
Absolutely.
Really? Because sometimes people might think, I don't need somebody to tell me where I put my mobile phone.
Well, I suppose it's about how we pitch the intervention as well. And again, people participate in the programme who are consenting to participate, who have a level of awareness that these symptoms are disrupting their day-to-day routine, and they're open to taking on that education. If it is that people don't see or understand or don't recognise the problems are there, then they may not benefit from that particular intervention, but they may another.
We also would sometimes use assistive technology in those situations. So, for example, if the person is resistant to having a safe place because they don't like the idea of somebody knowing where they keep their keys or where they keep their wallet or purse because it makes them feel a bit more vulnerable, there are devices such as item locators that you can purchase that will emit a sound similar to if you lose your mobile phone and you
Find my
if you
phone.
use my phone and you just follow the beeping. So there are options if the person doesn't want to go down the mainstream, but by and large most people will like the strategies and the routine and the safety it gives them. Because often people feel safe in routine and safe with knowing where they're going and they feel more confident. And sometimes it's just improving their confidence to manage their own day-to-day routine. They actually will try a little bit more.
Confidence is key. Can you give us some examples of the kind of practical tests that you would ask people to do when they come to see you first? Things around the house, ordinary day-to-day tasks in the kitchen, for example.
So sometimes we would add in an objective functional assessment that is occupational therapy specific. And that is what we call the AMPS. So it's the assessment of motor and process skills. It is slightly different than our other measures because it's criterion referenced rather than norm referenced. That just means that the criteria we look for is competent performance. So when we start off to do that assessment, we would have a detailed conversation with people about what does their daily routine look like. In the hospital, we have a fully functioning kitchen, we have a bedroom, we have a bathroom, so we can actually replicate an awful lot from somebody's daily routine. Typically, it will be making tea and toast, it might be ironing a shirt, it could be hoovering a small room, it could be making or changing a bed. So things that are very relevant to a person's daily routine. They don't always see the link as to why we're doing them from a cognitive point of view, but it gives us an awful lot of information about what general elements are breaking down that are causing that disruption, and then again allows us to tailor interventions specific to that task.
And do people ever say, well, this is not my kettle, or this iron, I don't know how to use it, it's not my usual iron?
Absolutely.
We accommodate for that by opening the assessment with a full environmental orientation, showing them how to use each of the devices in the room down to the taps, how they turn, which is hot, which is cold, exactly where all the items are located. It's important to try and set up the environment to replicate their home as closely as possible. So we will spend time, 10-15 minutes before we start the assessment, moving items so that they are in a logical, comfortable place for the person. So if they have their cups on a tree on the counter, we make sure the cups are out on the counter, not hidden away in a cupboard so that it feels alien to them.
What is it you would like people to know about coming for an assessment with you?
I think it's just really important for people to know that, as Fiona mentioned earlier on, there is no judgment on anything that they will come to tell us. We are here to offer full support. We will spend a lot of time talking them through all of the symptoms they're experiencing, all of the day-to-day difficulties that they might be having, no matter how small or big they may be, and that if and when a diagnosis of a condition is found, there is an array of supports. I mentioned Opticog for people with mild cognitive impairment, but for people who maybe receive a diagnosis of a neurodegenerative condition such as Alzheimer's disease, there are a lot of post-diagnostic supports, family supports, and different therapies depending on where they're at.
And how would those different therapies have evolved over the years and supports compared to maybe 10, 15 years ago?
Well, it's kind of day and night. Obviously, the medical marvels that are happening with the modifying drugs potentially coming out, but I think people are much more aware of the conditions, and there's a lot of time and space gone into assistive technology and devices to actually support memory and routine. Here in the hospital, we're not huge into sending people off to buy specialist disability equipment, but we would look at working with people about adapting their current mobile phones, setting up text reminders, alerts. The use of Alexa and Google Home, other devices do exist, but using reminders, using technology for families and the person to support each other. One of the big wake-up calls and one of the benefits from COVID was that people who we didn't think ever would use technology suddenly did. So people are able to manage online shopping, they're able to use FaceTime, they're able to use apps on phones that we perhaps didn't give credit because we hadn't thought about it 5 years ago. And so a lot of our advice will be tailoring towards using mainstream technology as well as our calendars, as well as our whiteboards in supporting people with their daily routines.
I can see your face lighting up when I asked you that question, and you're smiling now. You clearly are very immersed in your work.
Every day is different and every person is different, but I think if we can make one person's journey a little bit smoother, give them a little bit of reassurance, then our day's work has been worth it.
And what's a good day for you, Emma?
Similar, really. A good day for me is seeing somebody coming in who's feeling a bit anxious or apprehensive and are walking out feeling supported, they're feeling heard, they're feeling really listened to, and that they have really been understood, and that they know that there is a purpose to everything we've asked them, and that we are actively going to follow through and make sure that they're given everything needed.
There's a certain cohort, a certain age group of women whose symptoms have been dismissed by GPs for years as potentially hormone-based due to menopause, and they really are frustrated. They almost come down defensive when they sit in front of you and go, "Oh, you're going to tell me I'm wasting your time." It's like, absolutely not. If you're concerned, you are in the right place. A couple of hours of our time, even if there is no diagnosis, if it reassures you, well then
It's worth it.
Come back to us in a couple of years and at least we have a baseline.
Occupational therapists Emma Nolan and Fiona Tobin bringing us to the end of this podcast. It was so encouraging to hear from them about the increased levels of support and care now available to those with a dementia diagnosis and their families. Alzheimer's, particularly early onset Alzheimer's, affects a person's speech and language. Next time, I'm with speech and language therapists Lisa Sheridan and Megan Ryan and learn about their role in the process of reaching a diagnosis and how they can work with patients to help maintain their ability to communicate after diagnosis. I'm Fionnuala Sweeney, and you've been listening to The Many Faces of Alzheimer's, brought to you by the Institute of Memory and Cognition at Tallaght University Hospital, Dublin. This series is available on Tallaght University Hospital's YouTube channel or wherever you get your podcasts. If you found this episode helpful, please share it on and subscribe to the series to catch up with earlier episodes.